Okay, so I think we already have people lined up at the question, so if you want to go ahead.
Yeah, thanks. Cheryl Mathias, I'm with CTAC, the Coalition to Transform Advanced Care. It just strikes me, I mean, I live in the world that was just discussed as opposed to learning from most of the world that's been discussed the rest of the day. And we heard three very different presentations, but all extremely meaningful for what we have to do and what we can do. From Lori, we heard what is mostly what I hear every day, which is, what are the things we're doing right now, concrete, small, you might say in some ways small ball, but not really, because they're the only way, in my opinion, we can get things done around here. From Diane, we heard a list of things that we've been dealing with for years and years and years since HCFA, right? And each one of these is huge, and trying to get anything done with any of them is huge. And then from Andy, we got the philosophical view of, what are the things? This is the person who ran CMS who's giving us the big picture of where we need to go. And I think it would be interesting for us probably to hear each of you, if you wanted to say what is the one thing that we should be focused on, because the next panel is going to supposedly talk about implementation. What's the one thing that you would focus on if you were this group for the near future, if each of you would do that?
I think that the most important thing that's likely to possibly happen is this cap on Part D in the Medicare program, which would be very important to that million of people who exceed it every year, and which would give some sense of security to the many people who are dealing with these specialty drugs that are just cost-wise out of sight. And I think, going to Andy's point, we don't want people who have cancer to turn away from their treatment because they don't think they can afford it.
So, I think there's a near-term potential meeting of the minds and opportunity in the next, within the next year on prescription drug costs. And I think that will have a significant impact on a lot of people. And so I think that's very real, and I think, we may know soon whether or not there's something that can happen there. I think that there's an overhang, which is this Texas court case, and how much people would be set back if we saw a bad outcome there, and the Congress voted along pretty much party lines yesterday on where they stood on that case. So I don't think we should pretend that we are moving on to the next thing yet. We're still living under threat, and that means that the next election cycle is going to be pretty important to that.
It is fascinating, the different perspectives on this panel. I love it. All the different layers that we're looking at. From a practical standpoint for seriously ill individuals, I do think it is restructure of the hospice benefit for the seriously ill, so more people get access to holistic care sooner, and then they get timely and appropriate access to hospice when they need it. And when I say that, I mean the full benefit of hospice versus whatever supportive needs they need from an interdisciplinary team further upstream. So I think practically for the seriously ill population, I think I'd love to see us focus on that. From a policy perspective in general, it's such a tension in two ways to me. A care model versus a business model. And we see that even in hospice care. It's being eaten up by a business model when it's supposed to be a care model. And you don't get the best outcomes when you make healthcare a business model. So that's a concern. I know that's more than one. And the other thing that I really am struck by, the tension of the day, is moving healthcare from disease-oriented to wellness and health-oriented. Because even in hospice, I feel like we heal. We heal people in spiritual, emotional ways. We heal families when we listen to them and go with what matters most to them in that process. And right now, that's a big tension here between the models of care that one's based on disease and illness, and one that we're trying to get to is based on health and wellness.
All right, let's go with this side of the room.
Pat Bomba, geriatrician in New York State, where our length of stay on hospice is so short. It's trying to extend it to, it's not about prognostication, it's about so many other factors. But I do have two questions about the rural access to hospice. One, does it include a change that it's only the physician that can authorize hospice, and whether or not nurse practitioners who practice independently in those states can also authorize hospice? That's the first. And second, is there anything that can be done, or is there anything in the legislation to help rural hospices that cannot provide some of the care? Some of it would be with changing the benefit, obviously, but for folks that want and need palliative radiation, small hospices cannot afford it with the per diem, and that oftentimes relates to short lengths of stay, which then are problematic for the small hospices. So it's a vicious cycle. So those are the two questions.
Thank you very much. The rub with the NP is beyond just the rural health bill, right? And there's been talk about trying to get that changed, and I think we need to keep working on that, because I think that we're going to see that nurse practitioners and physician assistants, any physician extenders, are going to become critical. I mean, when we look at those statistics, right, how are we going to get this done? So we need to stay on that and try to make that happen. But I think that's a longer battle than the rural health care bill. You can be a nurse practitioner and be the primary care provider, but we still need that physician to sign. And I know that's not what we want to hear, but I don't want to delay getting the rural health through to add on that additional piece, but we want to work on that piece. The other thing, I worked in a small community hospice in Pella, Iowa. It was unusual because it was a bit affluent. Anybody have Pella windows, or Vermeer Manufacturing was there. So it was a bit unique in that way. But we always offset some of those costs with donated funds. And so that's one, and we partnered with, say, the radiologist oncologist to say, can we do a negotiation with you on what we pay for? You know, maybe we pay the professional fees, but we waive something else. So there's a lot of creative ways to do that. I think, again, because the business model seems to be taking over a little bit, sometimes we've lost some of that thinking outside the box. But that's another reason for maybe looking at restructuring the hospice benefit so that maybe we don't have to make those kind of, I can't imagine as a patient trying to make those choices. And it just seems counter to me that I should have to make those choices to get access to a hospice benefit, just like it seems counter that you get penalized if a patient lives longer on hospice, and, you know, longevity and quality of life are good outcomes, but then we have to discharge them from those services. And ironically, they don't ever want to be discharged once they get those services. It might take a while to get there, but yeah, those are challenges we need to overcome.
So I appreciate your comments. I would just say in some of the small impoverished areas, there is no opportunity for fundraising because there's not a Pella window to help with that.
Right.
And the second is, as a follow-up question, is there a separate bill to authorize nurse practitioners, not just in rural areas, but other areas, to be able to enroll a person in hospice? Is there a bill that's existing today?
Yeah. Yes.
So it's part of a larger bill, not a separate bill.
It is one of the key aspects of that bill.
What was the name, Marion?
Removing barriers to care.
Okay.
In the White House.
Yep.
It's only a Senate version.
Okay. Thank you.
Marion.
I'm Marshall Chin from University of Chicago, and thank you for your insights and many national contributions over the years. I was a bit concerned, however, given that you are three of the most respected, influential, and powerful people in the room today, that of the various panels, yours was the one that had the least amount of a health equity focus. Diane in her talk, she had the last slide about like the fruits and tailoring the solutions to the different patients. Andy talked about systems, the need to tailor systems. Most of your policy recommendations were more general, many around coverage, which would clearly help. But as I heard throughout the day, starting with Bridget's powerful story as an African-American woman with breast cancer navigating the system, most of your solutions didn't specifically address how would you advance equity among diverse populations. And so I'm wondering, do you have further policy recommendations that would explicitly support then the reduction of health disparities for these diverse populations beyond what seems more like a rising tide lifts all boats for a variety of vulnerable populations?
One point, I think that a rising tide sometimes does help, but it doesn't close gaps. And the research that we've done in our work on disparities shows that the Affordable Care Act, through its coverage and especially focused on low income and on the expansions of Medicaid, where you do see many of the low income and minority populations get their coverage, has clearly demonstrated that that's a way to reduce some of the disparities, especially in access and especially in financial ability to get care. And we see when we look at the non-expansion states, some of the huge inequities that remain. And you can then look at, maternal mortality, as Andy pointed out. If you're trying to address those problems, some of the way you have to do that is to get those communities to have care coverage that's equal. And as we've known for years, coverage does not equal access in all cases, and coverage does not always equal better health, but it certainly is better than no coverage to try and advance those things. I think that you also need to have much more of a public health focus than we have historically had. It's not just financing, it's really looking at how to deliver those services. I think that we've seen in some states, Washington State is one example of trying to target zip codes that have the worst health outcomes and trying to merge the public health clinics, go in there with lead paint poisoning. And the one thing I think that's happened over the last decade or two is that we've really retreated from the kind of public health approaches that when I was at HICFA were still part of the partnership between healthcare financing and healthcare delivery. So I think those are some of the things we really need to do, and it's on the ground trying to do more community-based assessment. There was a lot of that embodied in the Affordable Care Act and in the preventive funding that was there that has disappeared because of the way that it's been poorly implemented. But that would be my solution, to really return to a public health community-based model that's coupled with the financing model.
I just want to say I really appreciate that comment, and I think that when we talk about policy, a lot of the times all of that explicit equity discussion does get sucked out of the conversation because it's quite frankly not always very popular to talk about what things explicitly are going to do for this or that community. But I do think there are a couple things that have been touched on today that would make a big difference. And we need to be very mindful of when we're making transitions to, for example, value-based care, that the pull-through of those changes are that the dollars are actually flowing to the things that we think are going to make the biggest difference and the biggest change. And so I said one thing I think that would make a big difference is, actually funding the services of community health workers, actually funding the services of community health workers who work with marginalized and underserved communities. And there's this big push from the healthcare system to work with all these new partners to bring all these community-based organizations into the fold. And those community-based organizations, by and large, are not seeing any increase in their funding. And we need to be really mindful of that as we do this work and as we go through this and make sure that we are guaranteeing that actually the changes that we're making at these macro levels are going to trickle down and enable the services that we think will be most meaningful. So I do appreciate that comment a lot.
And I appreciate your comments also. And because I think people like Diane and Andy and Laurie have over the years made such a difference nationally, again, perhaps more so than any of us in this room, that I'm making this comment that I think it'd be helpful complementing the general approaches with a more granular look at all your policy levers within access, within quality, within costs, of how you have an equity lens. One example being like community health workers, but I think there's a lot of unplowed ground that there's a tremendous opportunity, public health being one of them, but each of these different areas, there's tremendous opportunities.
Hi, Alice Chen from San Francisco. This is actually a question to Andy, and I want to hear more about the communist agenda. So basically, as a primary care physician and administrative leader in a system where 20 to 30% of our patients have diabetes, you know, the vagaries of insulin production and pricing are definitely concerning. And so I was really intrigued by this idea that there's some things that could be public goods. And what I'd like to hear more about is what might some of the principles be in terms of how we identify the things that would best fit in that category? 2, do you see it happening on a state or federal level or both? And 3, how politically feasible would that be?
Well, you know, we look at some past examples, and none of them are perfect analogies. But, you know, care for HIV and financing structures, kidney care and dialysis, there are going to be breakthroughs. And, you know, I think the public is going to demand that those breakthroughs be delivered to people who can afford them. You know, we have a 95, 96% cure rate for childhood leukemia now. It's very, very expensive. If we can cure a cancer, we cure Alzheimer's, the public's going to start thinking very differently about how we make sure that people have access to these things. I think it's much easier for people to think in these narrow examples oftentimes than what feels like everything for everybody. So I think insulin is just one of those examples that has, it affects so many, the cost burdens are so high, there's places where the fingers are getting pointed. One of the most active, I think, sources for a lot of this may be attorneys general, who are taking a look, as they are, with opioids right now and these other hot areas. They're increasingly making healthcare part of their agenda. Your AG is one of them, but many other AGs as well. So, I think we shouldn't just look in the usual places and say, well, what is Congress doing? What's the administration doing? What's happening on the big picture items? But you start to narrow in on some of these things, and if you look back on how progress has actually happened, it is this very uneven, yet very sensible, oftentimes, focus on a particular condition or a particular issue, a particular injustice, and a lot of energy goes behind that, and it's possible that insulin is the next one or one of them.
One of the ideas that's come up is an insulin really a preventive service to prevent people from ending up in the hospital and sicker, and so shouldn't it be part of the preventive services package that then is not subject to cost sharing? So, Andy, there's broad ideas that we can try and put out, but my strategy that I learned a long time ago is sometimes you do well to have a game plan of where you're going, and then you figure out the steps to get there. And so maybe starting to make insulin, as an example, more affordable gives you a case then that can be used for other things.
Good afternoon. My name is Tim Cox, and I'm the Senior Director for Post-Acute Care and Home-Based Services from Care First. So we offer healthcare benefits to the whole state of Maryland, all of DC, and Northern Virginia. I just wanted to share with you a practical example we've done in our benefits because access is really a concern, and we've discussed today. In our home care side, we removed the homebound requirement so people can get care at home without having to be homebound. It's really important because people, especially our population, mainly a younger population because we're a commercial insurer, people stop getting their wound care because they have to go back to work. and they can't go to the outpatient clinic. So our providers will see them before work or after work. Because they can work, they're not homebound, one step. Second, we removed on our hospice and palliative care benefit, we removed the 6-month requirement of impending death, and we also allow our members to get concurrent care. So I want to thank you all for being proponents of some of these changes, but on our side as a payer, we understand and hear, and we're trying to meet our members to be able to give better equity for the care that they want and that we want them to be able to get. So thank you.
Thank you.
Eddie Mochtinger from UCSF. Just following up on Alice's question about the insulin example. Today we're talking about health disparities, and individual, family, and community level trauma fuel much of health disparities, often mediated by behavioral issues like substance use, obesity, in particular mental illness. How do we avoid picking illnesses that are viewed as organic, natural, non-culpable? Diabetes is the perfect one. You've picked kids who don't produce insulin, yet you have then marginalized people who have substance use, mental illness, and other behavioral conditions that are thought to be volitional or even characterological, but instead are clearly related to lived experiences of people who are suffering disparities in America. And so I'm wondering, back to Alice's question, how do you, in the long term, if you share that value of making sure that those are not marginalized as characterological and bad, how do you then have a game plan that allows people to buy in to a certain goal, like covering insulin, but not have that support the marginalization of conditions that predominantly affect people who are racial minorities and poor people in the country?
I think it's a brilliant question, honestly, and it is a hazard. I think it is probably an underbelly of a sort of incremental approach. I think there's two things we probably have to do at once. One is take advantage of public sentiment where we have it, and the second is influence public sentiment. I am quite sure that mental health and addiction, because for no other reason than they are winning political issues for every candidate, are talked about more and stigmatized less because of the nature of the politics of those issues. And we have to, and I think likewise vaping, gun safety, all of these sort of issues that we tend to not think of as mainstream health issues, but really at a fundamental level affect our health and our safety as much as anything else. When these things occur, I think it pays to be opportunistic and remind people that, gee, we invest a lot of money in making sure that people like us have 7 Fitbits to count our steps, yet we don't have adequate mental health in most communities. And so we have those teachable moments, we need to run through them. Insulin, there is, because there's a sort of growing wave of awareness, and it's gettable and relatable, it's the same story. So, I think there's no reason for me to think that we should be able to do something and therefore exclude other things. But if we, to your point, if we fall into this sort of deserving and undeserving trap, or allow that metaphor to persist, we have gone backwards.
I agree with Andy, and I think that one of the things that we also have to keep always in mind as we try to advance policies is it's not just the individual, but it's how broad their reach is in terms of families. And all of our polling shows that we think of something as, 10% of the population has this. But how many families in America have someone with a pre-existing condition, which is why that issue became so potent. And so I think the way to keep things from being marginalized is to remember that they're part of a broader context and to try and always keep in mind that it's not just asking, do you have this condition, but does anyone in your family have this condition? What has it done to your family? Which goes back to the fact that it's the caregivers and the family members who make the policy happen in many cases, which I'm sure is really the case with how you build the hospice benefit and try to expand it and improve it.
Yeah, and it makes me think about the interrelatedness that we talked about earlier today, right? All of these things are interrelated, and I how do you separate one thing like diabetes with and insulin dependence from this whole interrelatedness? And I think if we keep that construct and that concept of interrelatedness, we don't marginalize pieces of a person or a population. That's just my thought.
And then I would just say also that when you think about these things, you could also look at stigmatized conditions and then make an analog to other things. So one of the things that my center does is we've sued state Medicaid programs over failure to cover hepatitis C medications for individuals who have hepatitis C but don't have stage 4 fibrosis, by which time your liver is very compromised, to be able to access those medications, and have been successful in multiple lawsuits. And one of the analogs that we've used, in addition to all of the good legal arguments, and so I would say definitely look to the lawyers in the court and the courts as allies in this scenario, but one of the things that we used was, if there was a cure for Alzheimer's, we would not be having this conversation, right? This is a stigmatized illness. This is the only reason that the situation exists. And that's been very powerful messaging around that particular issue when we're making those arguments.
Thanks.
And I'm being given the sign to wrap it up. So thank you so much to all of our amazing panelists. Thank you to the audience for your thoughtful questions. We really appreciate it.